Well, we'd like to move ahead to our next session. I'd like to request our chairperson, Dr. Sanjay Desai, to please step forward. Ladies and gentlemen, this session is very, very important. It is brought to you by Servier. We are looking out for Young Researcher Award. It is a competition. It is where the actual action begins. We have about 10 participants who are participating in this particular session, and the lookout is to figure out who the Young Researcher Award winner is going to be. And this entire session is being curated by Dr. Sanjay Desai. We've been waiting for this, and this is the moment, very, very important. I'm sure this is getting excited. And I'd like to remind our participants that the time limit per participant is 7 minutes only. 7 minutes only. We have our judges seated around the room, and we are about to begin this particular session. Over to Dr. Sanjay Desai.
Thank you. Can we have a small announcement for anybody outside to come in now, please? I think there are a lot of them on the stalls, so if we can request people to come in.
And to our presentation, presenters, please make a note. The time limit is 5 minutes for the presentation, and the last 2 minutes, the floor is open for Q&A. 5 minutes is the presentation. Last 2 minutes, the floor is open for the Q&A.
Yeah, so good evening. I think this is one of the sought after or most looked up sessions in the VAI. This is definitely an encouragement for the young training surgeons. It has really added value to their training because I've seen a lot of them who have participated in this, and they put quite a bit of effort, and any award or a reward, whatever it is, makes a lot of difference. It's like we all know, it's not what is behind it, but the recognition which comes with it. So we should be starting in some time now. Just to let you know, this is going to be judged. I am here to chair this. I'm one of the judges, and we have another 6 judges in the audience. A lot of them, I myself don't know who are judging, so you have people in the audience who will be judging you. And the questions can come from the audience. Anybody who is interested, at each end of each paper, you could ask the questions. The judging will be done as usual. We have divided into 50 marks, and 10 will be on the study design and the statistical analysis. The other 10 marks is for background methods, methodology, and the discussion. Timing of presentation carries 10, so I think everybody please take note of that. So your timing is important. If you go beyond time, there is some deduction. And contribution to innovation, how innovative is your topic, your research method, and the idea makes a difference. And of course, question and answers. Just for the young trainees and who are going to present, question and answers, please don't get bogged down whether you're right or wrong. You're trying to do a research work. You are trying to find out what something is better or may not be better. So please be frank, please be bold enough to answer the questions with what you know. Ignorance is not something we are here to know. If you don't know the question, you can always ask for clarity, or you can always tell what is your idea with this. That's how research grows. If we don't question, research never grows. So if everybody is ready, Prabhu, we can start. We can start? Okay. So we just have a little bit shift in order of presentations. I think by the time we get organized with the other presenters, I will call upon Dr. Nivedita Vitta to present. I think she was number 3 on the list. All judges, please note, this is Nivedita Vitta. No, sir, that's why I said there's a change in order. So on your list, kindly make a note who the presenter is. Yes, there was Piyush. Piyush we are just getting organized with his presentation. So that's why I said all the judges just make a note as and when the presenter comes. It is not on the order in which it was given before.
Good evening, everyone. I'm Nivedita from Ramaya, final year MCH student. So my topic is the modifications that we can make to 4-layer dressing to further benefit the patient. So as we know, venous ulcers are one of the most common causes of leg ulcers, and there is a very high recurrence rate which is associated with that. And 4-layer dressings have proven to have revolutionized the treatment of non-healing venous ulcers. So these are the basic principles of using a 4-layer dressing. Basically, for ambulant patients, a high pressure dressing is required, more so in case of associated lymphatic drainage. And sustained compression is required not only to empty, but also to avoid refilling. And current evidence shows that 4-layer dressings are the most effective and also cost-effective method of preventing recurrence and also in healing. So to prove the efficacy, we undertook a prospective study in Ramaya, and this included 70 patients. And our study showed that a maximum number of patients were in the age group of 41 to 50 with a moderately big ulcer. So this shows that it was a burden to these patients and their families, not only in terms of reduced work hours, but also the financial liability of the same. So with regular 4-layer dressings, we saw that these wounds healed much faster at 4, 8, and 12 weeks. So again, coming to reiterate the fact that conservative treatment with 4-layer dressings has shown to bring down the ambulatory venous pressures and helped heal these ulcers. So what can we do to make this better? So I propose the use of probiotics and specifically lactobacilli to improve the wound healing. So the proven mechanisms that are understood behind this are that lactobacillus or probiotics are non-pathogenic in nature. They have also been found to not interfere with the normal commensals, and it's supposed to bring down the edema and erythema associated with these ulcers. Another important factor is that it prevents infection. This is by creating an acidic medium in the site of the ulcer. So a neutral or an anaerobic medium which actually propagates the growth of other bacteria is taken care of by the application of these lactobacilli. And prevention of, and also another factor is the anti-inflammatory role. That is, they are seen to replace all the active inflammatory products with interleukin-8, which also helps in the elastin and the collagen deposition and improvement of wound healing. A major role of these proposed in the, by these lactobacilli is the prevention of biofilms. Biofilms are considered a major problem in healing of venous ulcers because the large size of these venous ulcers and the associated multibacterial flora. So this is the definition of ideal wound dressing, and I would like to state that application of lactobacilli or probiotics does not interfere with the ideal wound healing dressing. So the aims of our study are basically to assess the effect on wound healing, to assess the effect on wound bacteriology, to negate the need for antibiotics, to bring down the overall financial burden, and as a corollary, to also study the effect on specific bacteria, in this case, Pseudomonas. So our inclusion criteria are venous ulcers, exclusion criteria are patients with peripheral vascular disease or other immunosuppressive diseases, and people who are not compliant. So the study design is that it would be conducted over a period of 1 year plus 1 month of follow-up. Patients would be randomized as odd and even, and tissues or swab culture with ABI will be taken at the initiation of treatment. Application of a generic probiotic or lactobacillus will be applied at each change of dressing after a generous and thorough wash with saline. And a 4-layer dressing would be applied by a trained professional. The ulcer size would be measured at every change of dressing, and a tissue swab or a swab culture is taken at every 4th, 8th, and 12th week or change of dressing. The time taken for wound healing would be measured, and whatever data is required will be calculated from the patient records. So these cards would be given to the patient, the green one for the patients on lactobacillus, the red one for those who are not, and as and when changes occur, those will be added to these cards. We anticipate a few confounding factors like use of antibiotics, whether oral or IV. This is during the study or 1 week prior. Surgical or endovenous treatment that is associated lymphatic disease, and specific bacteria. Endpoints of the study would be wound healing, that is these patients would be called back at 1 month and then assessed and termed wound healed. All standard of care will be borne by the patient, and product used and culture will be by the study person. So these are my references. As we can see, it's been established use in burns and in chronic ischemic ulcers, also in fungal, because most of these are in the lower limb, so associated fungal infection is possible. And apart from that, it is also seen to have multiple other uses. Most importantly, I would stress on replacing antibiotics is a possible outcome of use of lactobacilli. Thank you.
Thank you, Nivedita.
Thanks.
Any questions? Yes.
Excellent study,
Thank you, sir.
but are you comparing it with any other modalities like a 2-layer bandage?
So actually we looked into that, and what we found is that because of a prior pilot study that we did, most of our patients have a big ulcer with high exudative wounds. So we would prefer a 4-layer dressing over a 2-layer dressing, and as a study protocol we are including only 4-layer dressings, and the only variable would be lactobacillus application.
And second is, how do you document the improvement in the ulcer size, healing, and how long do you like to follow up this patient after they heal? The problem here is recurrence.
Yes, sir. So the size of the wound would be measured at every change of dressing, sir. For this, we would use a plotting graph, and based on that, a measurement would be done, and that would be kept in the patient records, a separate file for each patient. And the second question, sir?
How do you follow up these patients after they get healed? How
Yes,
long
sir.
do you want to keep them?
So one was the definition of a wound healing at the end of 1 month after epithelialization. And the second thing is, even though it is not part of the direct part of the study or our aim, these patients would be in our records, and we would be following them up at a regular basis, because one extended study could possibly be if lactobacillus prevents recurrence or has any outcome on that, because it has been shown to have a general well-being effect on the patient's healing.
And any topical antibiotics you are not planning?
No, sir. We
don't
would,
have it.
no, sir. That is the thing. If at all, IV or oral antibiotics.
Dr. Edwin.
Thanks, Sanjay. Nivedita here to your
Yes, sir.
left.
Yes.
Yeah, thank you for that study.
Thank you, sir.
In the abstract that you have presented, you had 145 patients. What is the number that you need to say that this is going to be effective or not effective?
Yes, sir. Sir, there was actually a little variation because of the submission criteria, but the thing is, we are taking over a period of 1 year, sir. So there are no acute numbers that we have calculated yet, but the thing is, over a period of 1 year, plus 1 month of follow-up, sir.
So
Statistically, we haven't calculated
a
the number of.
That's it. Well, no more questions. Thank you, Dr. Nivedita.
Thanks, sir.
One moment, sir. We do have Dr. Piyush who's joined us virtually. Dr. Piyush, if my voice is audible to you, you are requested to unmute and speak to us and let us know that you are ready for the presentation.
All the colleagues and seniors.
Over to the chairperson.
I'm sorry, I wasn't able to hear. It's echoing here. So it's Piyush's. Okay. So is he ready? Okay.
Yes, I just shared my screen.
Yes, Piyush, please. This is, judges to note, this is Piyush. Piyush, we are,
Good afternoon, everyone.
we are audible to you?
Yes, sir.
All right.
You are.
Okay, Piyush, you can start.
So I am Dr. Piyush. I work in vascular surgery department in Fortis Hospital, Mohali. Today, I am going to present the initial outcomes of 1940 nanometer diode laser in the treatment of the epiphyseal veins. As we all know, endothermal laser ablation is now recommended as the first line treatment of varicose veins. And out of these veins, epiphyseal vein treatment with laser in itself is a new challenge because of its anatomical location. So this study is to find out the outcomes of treatment of epiphyseal veins with 1940 nanometer laser and using infinite fiber. This was a prospective observational study. We treated 25 patients, out of which 16 were females and 9 were males, and they had incompetent SFJ and with epiphyseal veins. We used 1940 nanometer diode laser and infinite 5-ring fiber to ablate these epiphyseal veins. We used this ringed fiber 1470 nanometer because it has proven to be having advantage over the other wavelengths. So the laser power was again set to the 5 watts with a mean linear endovenous energy density of 40 joules per centimeter. Also sufficient amount of tumescent anesthesia, around 300 to 400 ml, was put around properly around the epiphyseal vein. So we were looking for the closure rate, the postoperative pain, postoperative bruising, cord formation, and thrombophlebitis after the treatment of these epiphyseal veins with the laser. So after the 6 weeks, closure rate was 100%. And the VAS score was recorded intra-op and post-op, which was around 5 and 0.65 respectively. And also after 10 days and 6 weeks of the treatment, which was around 0.8 and 0.47 respectively. There were some complications which we encountered, and they were thrombophlebitis and bruises in approximately 18% of patients. There was no case of endovenous heat-induced thrombosis, but there was cord formation which was observed in 8 patients. So in conclusion, the 1940 nanometer laser and infinite fiber at 40 joules per centimeter showed satisfactory initial outcomes with less pain and fewer complications. We think that it can be a good alternate to foam sclerotherapy and phlebectomy. Also, this epiphyseal vein treatment should be done with utmost care, but further studies are required to find the efficacy of EVLA in epiphyseal veins. During my search, I could find a study which was published in July 2021 by Dr. Park, in which he treated these veins with clarivane. Also, only thing which was feared was hyperpigmentation after such treatment of epiphyseal veins, but I could not find any study including laser treatment of the epiphyseal veins. Thank you.
Thank you, Piyush. Any questions from the floor? Well, Piyush, before Edwin reaches the mic, I'll ask you a question.
Thanks, sir.
Yeah, can we see Piyush, please? Piyush, you can stop sharing your screen.
Right, sir.
Just your video. Okay. We are audible to you, right?
Right, sir.
Yeah, Piyush. Just towards your conclusion, you said further studies would be needed to confirm your findings or make it a definitive treatment as an alternative. How would you intend, or is there a plan to have, what would you do if you had to further this study?
Basically, we have to find an appropriate treatment modality for the epiphyseal veins. Like we can use, as in the study by Dr. Park, he used clarivane, that MOCA technique. Simultaneously, we can use just sclerotherapy or the laser treatment, and we should compare the outcomes with these modalities, that which modality is best for such kind of veins. So in our study, we used laser treatment to see the results, how it goes, because it is the standard for the other veins. So we thought that putting a good tumescent anesthesia and this 1940 nanometer laser fiber, using 5-ring and infinite fiber, we can get some good results. So we can compare these treatment modalities and come with the best treatment modality.
So you want to do a direct randomized study comparing head-on with other alternatives.
Yes, sir.
All right, Piyush. Dr. Edwin.
Hi, Piyush. Thank you. Good study. A couple of questions. The first one is, what was the indication for treating the epiphyseal veins in these patients? What was the indication? Number one. And number two is, you found almost, what I would say, more than 15% of cord formation. So do you think
Right,
the
sir.
wattage was a bit high? Would you recommend a lower wattage?
Sir, coming to this, the indication for treatment of these epiphyseal veins were like, these were the main veins which were leading to the varicosities, and those were directly linked to the vein leading to the SF junction, which was incompetent, leading to the main vein filling the varicosities. So that was the main indications that we should close these epiphyseal veins. And course of the GSV was in some cases partially intrafacial and partially epiphyseal. So we had to close these veins epiphyseally. And sir, could you repeat the second question?
You had about 15% or more of cord formation. So do you think the wattage was high?
It may be high. So we tried with the 5 watts and lead of 40 joules per centimeter, and putting a good anesthesia, we got this cord formations. But we think that yes, lowering the watts can result in a better result and non-formation of these cords. So we were just starting with these analgesics.
Piyush, can you just clarify what you mean by epiphyseal? Is it treatment of other varicoses apart from the long saphenous vein? Because I'm not clear what exactly you mean, what veins you are treating here.
So epiphyseal, the truncal vein which becomes epiphyseal, it's a GSV which becomes epiphyseal after the mid-thigh,
Okay, so
and
you
leading to the distal varicosity.
and you combine it with other procedures like stab avulsions or on-table sclerotherapy or what?
Yes, sir. In addition, we do form sclerotherapies.
Sclerotherapy or stab avulsions?
Sclerotherapies.
You don't do stab avulsions?
No, sir.
Not even bulky varicose veins?
No.
So what percentage of foam you use and how much is the volume you can use?
So like in each leg, like around 8 ml of foam, like 2 ml of liquid.
That's sufficient to
In each leg.
close all these veins, big veins?
So we try when we fix this truncal insufficiency. So we hope that most of the varicosities, they will reduce by themselves because of the closure of the truncal reflux. And most of them, yes, with 2 ml, we can close them, yes.
And you mentioned 300 to 400 ml of this thing, saline infiltration. What do you use, hand infiltration or do you use a pump?
So we use a Klein pump, and usually 300 and 400 ml, it's the maximum because it totally depends upon the technique, how you put the tumescent anesthesia. So when you are very good at it and you can just manage with like 100, 150 ml and with a good formation of fluid tunnel around the vein.
What anesthesia do you use?
We use ringal lactate and with lignocaine, 2%.
So no regional anesthesia or GA?
No regional anesthesia.
Thank you, Prakash. Thank you, Piyush. I see you're working, you're holding fort there, and thanks for joining us, and you can get
Thank
back
you,
to
sir.
work.
Thank you, sir. Thank you, sir.
All right. Are we on order now? Okay. So, Manohar, the next speaker will be Manohar. Dr. Manohar? Yes.
Good afternoon, everybody. I'm a vascular radiologist working with vascular surgeon in Western Maharashtra.
Requesting speakers to please come closer to the mic while speaking. Over to you, please.
My topic is ultrasound-guided suprafacial laser ablation of perforators. UL is a well-established treatment for chronic venous insufficiency. There is strong evidence that interruption of the incompetent perforators minimizes the long-term sequelae of chronic venous insufficiency and reduces the recurrence of venous stasis and ulcerations. Objectives of our study are: it is logical to assume that definitive ultrasound-guided perforator ablation will yield similar results as that of ACPS. We are presenting our largest study about the ultrasound-guided suprafacial laser ablation of perforators with saphenous veins in single setting by ULA. This is a prospective study to determine whether ULA could be used solely to treat perforators above the fascia. Materials and methods. From January 2019 to November 2021, in 350 patients, 3,880 perforators were treated by ULA under spinal anesthesia in single center by team of radiologists and vascular surgeon. Inclusion criteria: perforator diameter equal to or more than 3.5 millimeter. Reflux on Doppler. CAP class 2 to 6 were included in this study. Exclusion criteria: that is thrombosed perforator, known case of DVT with partial thrombosis of perforator, local infections. Based on the locations, in thigh we have ablated 64 perforators, in the leg 3,709 perforators, and in the foot 107 perforators. All the patients were treated under spinal anesthesia. Logic V5 ultrasound system was used for localization and guidance for the puncture of the perforator. Perforators were punctured with 16 gauge Gelco under real-time ultrasound guidance. 1470 Vela system was used with bare fiber. This is the first image is normal competent perforator. In second image, the perforator is dilated with reflux on Doppler. Please play the video. Please play the video. This is how we are doing the puncture of the perforators. After putting the Gelco in the perforator above the level of fascia, the fiber was passed, this sheath was withdrawn. Saline infiltration was done around the perforator. Then we started the ablation. Please play. This is a residual perforator after ablation of the GSV. Please play the video. Again, same technique. The advantage of perivenous infiltration with ablation above the fascia is the fumes which are generated, they are going in the superficial veins instead of deep veins, with additive effect on the ablation. All the patients were admitted in the hospital for 1 day, and follow-up is done after 2 weeks. This is the ablated perforator with absent flow in the perforator. The second image is the flow is there below the level of fascia, and the flow is absent, that is thrombosed above the level of fascia. So results: in all the patients, single puncture was sufficient. 250 to 350 joules of energy was given depending on the diameter of the perforator. Treatment was successful in 3,635 perforators in single setting, that is about 93%. Residual perforators were treated in second setting during same session, resulting in 100% obliteration. After treatment, ultrasound surveillance within next few days confirmed that perforators were all occluded. Bruising noted at the site of perforator. There were no late complications. There is no published data about the suprafacial perforator ablation. So we have compared our study with recently published article by Gibbs et al. In 2020. We are having better results than this study about the perforator treatment. And why laser? Laser gives similar results as that of ACPS. Ultrasound-guided puncture of the perforators causes less trauma to the adjacent structures like muscles and nerves. Significant length of the draining superficial vein can also be ablated during the same session. Why superficial perforator ablation? There is safe distance from the deep veins in case of direct perforators. Perivenous infiltration disconnects the perforator from the deep veins temporarily. So the fumes will go in the superficial system and there will be additive effect. We can treat any number of perforators, postulating the risk of compartment syndrome in case of treatment of multiple perforators. This is safe technique. Adjacent muscles and neurovascular bundle get less thermal energy. In conclusion, all the disease perforators can be treated by ULE along the saphenous veins in all the cases above the fascia without any significant complications. It is safe, cost-effective with comfortable recovery while maintaining minimally invasive treatment. This is promising technique which will require more research and more practice. These are the references. Thank you.
Thank you, Manoj. Dr. Harinder?
Yeah, Dr. Manohar, thank you for the presentation. Now you mentioned that you have treated C2 onwards.
Yes, sir.
Treating perforators C2, C3 is not currently, the standard of care. And number two, you mentioned about the use of spinal and admission. So is that the usual for your hospital that you admit all your patients?
Yeah, we are doing GSU ablation perforators in the same setting.
No,
Because
no, I'm asking if you are supposing not doing the perforator, would you still admit and give spinal?
yes, sir.
So that is the standard of care.
Yeah, we are doing
So why are you treating C2, C3 perforators?
C1 patients. Usually we advise conservative treatment or foam sclerotherapy for C1
No,
patients.
no, but C2, C3 is, your perforator doesn't need to be
No, if there are incompetent perforators during
incompetent perforator, C2, C3, you don't need to do anything.
yeah.
It's only when it is pathological. And you didn't mention about the duration of reflux. I presume you forgot. You mentioned about the size, but you did not mention about the duration of the reflux.
Okay. Yes.
Manoj, just on an average in a patient, here Manoj to your left, here. On an average in a patient, how many perforators were done
Around 8 to 10 patients in single limb.
in the single limb?
Yeah.
Okay. Because I see that it says the largest number of
Yes.
what you're presenting.
Yes.
So we have about 350 patients and about 5,800 perforators.
Yes, sir.
So that will roughly amount to about 20 perforators per limb.
No, I'm talking about single limb. 7 to 8 perforators in single limb in bilateral cases.
So you're talking about 700 patients
Average is about 15 to 20 perforators
per limb.
per.
Per
Yeah.
limb.
So can I ask you, so 15 to 20, so how much time do you take?
For surgery or perforator ablation?
No, like laser ablation
Laser
and plus perforator.
for single limb around 60 to 80 minutes.
You see, my thinking is what we have observed in the last 21 years, the more you do in these patients, the more complications patients has. Okay? And I really don't know that you need to close so many perforators in any limbs. And like, I think we should, now if you have stopped the study, then in future you should randomize the patients. In one limbs, you do maybe nothing, and then close 15 perforators, if you're closing maybe 7 to 8 perforators per leg, and then follow up these patients at 6 months to 1 year.
Yeah.
And then see, is there any benefit of closing so many perforators? Because at present, we need to know that what we are doing to the patients, it's not about only closing the perforator, is it helping the patients or not? Because there are a lot of studies which have shown that if the perforators are not incompetent, and if you close the main veins, the refluxing veins, then you don't need to treat the perforators in the follow-ups. because of the venous hemodynamics. So, and also I personally am very against putting the spinals and putting 60 minutes to 90 minutes on one leg. If you're doing 2 legs, it means 2 hours of venous surgery. And definitely that will increase the incidence of DVT, you know. So, there are a lot of ifs and buts to my mind. I don't know, but what do you think about it?
The problem of our practice is we are practicing in remote areas. So there is one problem of cost. The other one is patient never come to follow up at design time. So whenever they come to us, they came with complications. This either the residual veins are thrombosed or there is ulcerations. So they want treatment, all the treatment in single setting.
All right, thank you, Dr. Miles. Sorry, we'll keep your question for the next. Okay, we'll move on to the next presenter. This is Dr. Gaita. Yes.
Good afternoon, everyone. This is Gaita Al-Mahrouqi, surgical resident from Oman Medical Specialty Board. Before I start my presentation, I would like to take the opportunity to thank the organizing committee for giving me the chance to present in today's conference, and I would like to thank my mentor, Dr. Edwin Steffen, for his guidance and support. The title of my study is Does a Patient Information Brochure Affect Willingness of Omani Women with Varicose Veins to be Examined by a Male Surgeon? It's a prospective randomized single-blind study. I'll start with a brief introduction. So varicose veins are not uncommon among Omani women, and what inspired me to proceed with the study is the fact that we don't have a female vascular surgeon in Oman. And it has been noticed in our outpatient clinic that the majority of our female patients are reluctant to be examined by a male surgeon, and therefore a management plan cannot be made. The main objective of the study is to assess the effect of an information brochure on patients' attitude, acceptance, and willingness to be examined by a male vascular surgeon in the presence of a chaperone. So the study was conducted over a period of 6 months, and we ended up having a total number of 100 Omani women. These patients were randomized into 2 groups using odd and even medical record number. The experimental group received a booklet, and the control group did not receive any brochure. We looked at the age, the marital status, parity, tribe, occupation, and the sleep classification, and these patients were reviewed a week later by a male vascular surgeon who was blinded to this process. The booklet contained information about definition of varicose veins, risk factors, symptoms, classification of varicose veins, and the different diagnostic and treatment modalities. So out of the 50 patients in the experimental group, 74% of them felt that the brochure had influenced their acceptance to be examined by a male vascular surgeon, whereas the majority of the patients in the control group refused to be examined by a male vascular surgeon, and the p-value over here was less than 0.05. Unmarried women in both the groups were willing to be examined by a male surgeon. Age, number of parties, tribe, occupation, place of residency, and the sleep classification did not affect patients' decision to be examined by a male doctor. In conclusion, I would say that an information booklet about varicose veins is effective as a tool to improve level of acceptance toward examination by a male doctor among Omani women. By this, I reach to the end of my presentation. Thank you for listening, and I would like to invite you to visit our beautiful country, Oman. Thank you again.
Thank you. Should I ask?
Yeah.
Thank you. Just wanted to ask you, is in the booklet, do you mention that you will be examined by a male vascular surgeon? In the information booklet, do you mention anything like this, that you will be examined by a male vascular surgeon?
Thank you for your question. We did not mention that in the booklet, but we actually informed, like we got a consent from these patients, and therefore we informed them that, that they will be examined by a male surgeon, and they were told about the idea of the study.
Fine. And why do you think that after reading the booklet, the people are okay to be accepted by a male vascular surgeon? Like, why male? It could be, they would be, after reading the booklet, they could be more prone to be examined by anybody. Why you are saying by male vascular surgeon?
that the knowledge actually would affect their willingness to be examined by a male vascular surgeon. So when they know about varicose veins and their complications and the consequences associated with the delay in the management, they would actually be more prone to be examined by a male vascular surgeon. So we wanted to look at the knowledge part of the study, the knowledge part of these patients and whether it would influence their acceptance if they were more knowledgeable.
Thank you. May I?
You mentioned about tribe as one of the, is there any particular tribe which is more prone for varicose veins?
Sorry, could you repeat the question again? I did not
Is there any
hear it.
particular tribe which is more prone for developing varicose veins?
No, we did not find any association between a specific tribe and the incidence of developing varicose veins.
You presented very well, Gaitha. Thank you for that. But I'm not clear at all why information booklet about a disease should affect the patient's acceptance. Was the initial counseling done by a male or a female when the patient came to you?
Because the thing is that the culture in our country is a bit different. So most of the females won't agree to be examined by a male surgeon, and therefore a management plan would be delayed. So we thought that actually whenever we distribute those brochures and booklets, their knowledge about the varicose veins and the disease itself would actually improve, and they would know about the complications associated with the delay in the management of varicose veins, and therefore they would actually agree to be examined by a male vascular surgeon.
No, I understand that, but the logic behind knowing about a disease and deciding about the male or female surgeon escapes me. But thank you, you presented very well.
Thank you.
Thank you, Dr. Gaitha. I think this is a point for all of us to note. I think research does not stop at just clinical work. I think part of this also forms a very much required aspect for a practitioner. So I think a very bold initiative. Congrats, Edwin. I think, I know it must be your idea. So thank you, Dr. Gaitha. So we'll move on to the next speaker, Dr. Samuel Prabhu. Yes, Dr. Prabhu. He's got a very short title, Veena 8.
Respected teachers and my dear friends, my topic for the research proposal is to develop a calf pump stimulator which can be powered by a cell phone to aid in the treatment of venous diseases, and I would like to call it as the it's not working. I would like to call it as the Veena 8. The presentation of venous diseases can range from asymptomatic to lifestyle-limiting limb edema or non-healing venous ulcers. Often the primary treatment, namely surgery, often addresses only a part of the problem. And most of these patients are advised long-term compression therapy, either in the form of compression bandages or stockings, manual lymphatic drainage, or pneumatic compression therapy. However, compression therapy has got its own limitations, as these cannot be used in patients who have got significant peripheral arterial disease or in heart failure, active infection, peripheral neuropathy, or as most of these patients are elderly who need some assistance to use these compression garments. And also definitely cost is also a major limiting factor. So the aims and objective of this present project is to provide a reliable alternative to compression therapy for the treatment of venous diseases. And the objectives are to develop a cell phone powered calf pump stimulator and to make it affordable and easily available alternative to compression therapy. So the calf pump stimulation has long been studied initially in the treatment of prevention of deep venous thrombosis with the help of this bulky instruments called thromboprophylaxis. And later on, when the cough pump's significance of cough pump has been studied, it has been shown to correlate with the severity of the venous ulceration and also its significance in the role of lowering venous pressure in the lower limb. This is the cross section of the leg showing the 4 compartments of the leg, the anterolateral compartment being supplied by the common peroneal nerve. And once the common peroneal nerve is stimulated, it acts as a stimulant to the calf muscle pump, and it has shown to improve venous blood flow and reduce stasis in the lower limb. And it has the same concept has been used to reversal of the lower limb edema, and there has been with the usage of plethysmography. So there have been few instruments which have come into the market recently. This device is called a Gecko, and this also works with the same concept of stimulating the common peroneal nerve. It has shown to accelerate the healing of the venous ulcers as well as in the edema. So what's the need for the present project, as already these devices are available? So they are not commonly available. And the second thing is a cost. The present device which I have shown, it costs around 3,000 rupees, and it works for 24 hours or 1 day. After that, it becomes dead and we have to replace the instrument. And why cell phone? So I thought cell phone would be a most accessible and a compact power supply to the device. So I would like to make use of the commonly available instruments like peripheral nerve stimulators used in anesthesia or transcutaneous electrical nerve stimulators and modify them according to the specified purpose. This is a tri-mode which I have mode in coordination with physiotherapy as well as engineering method, where a TENS probe has been taken and modified it to be connected to a cell phone. And it has shown to give some initial promising results which are yet to be developed. And once a device is ready, we would like to do a randomized control trial, and with a sample size of 180. And there are inclusion criteria with patients of C3 to C6 disease, and exclusion criteria being the patients with significant arterial disease and acute deep DVT, and patients who cannot understand how to apply this device. And outcomes would be either subjective by measuring the venous clinical severity score before and after using the device, and objective by measuring the limb girth and ulcer surface area. But the best would be a plethysmography. However, the feasibility and availability is not available. So this is a simplified flow chart where the patients would be diagnosed with C3 to C6 disease, and they would be assessed subjectively and objectively, and they would be randomized either to the calf pump group or as a routine compression therapy, and they would receive at least 50 milliamperes of current for at least 15 to 20 per minute for at least 4 hours per day. And once they have done this treatment, bi-weekly assessment would be done for at least 4 weeks, and then they would be assessed for 3 months, and then the data would be analyzed. So my conclusions are: calf pump stimulator, it can act as an important adjuvant in the treatment of venous diseases, and affordability, availability are the main limiting factors in its use. And the present project, if developed appropriately, can benefit a significant group of patients consulting vascular surgery. Thank you.
Thank you. Yes, Edwin.
Hi, Sam. Very nice presentation. Like the innovative side of it. With the nerve stimulators, you would have, it would be something that the patient would have to introduce, whereas the TENS can be applied over the skin surface. So are these patients going to go home with the electrodes? That's question one. How are you going to measure the amperage that you showed on your second last slide, I think it was, or the third last slide, that they would do this much time with this much wattage or amperage, because cell phones would have different battery lives. And the third question, lastly, in your pilot study, how long did that battery last on a cell phone when they were using it? How frequently did it need to be recharged?
Third question, sir?
The cell phone, how frequently did it need to be recharged?
Okay, sir. The first question, the patient will be given normal ECG electrodes, sir. You have to use the normal ECG electrodes, so I will give some ECG electrodes for him for use. And second question is the data which of the 50 milliamperes And 2 studies, one study has done 5 hours per day for at least 5 days per week, sir. They have done a study. I have not proposed a exact measurement. This machine which we have developed, we still don't know what is the current is producing, but we just known that the TENS cable can be connected to the cell phone and it's working. We are yet in the process, sir. And third question, sir. Charge, it depends on the cell phone only, sir.
It's an Apple i13 or not? Okay, tell me something. Have you seen somebody using this in their routine practice?
Not routine practice. I used it on my grandfather, sir. Even myself, I just used it.
And why do you think we are not using it?
You don't see them often, sir.
Why? Just think, like why we are not using it routinely? There is a Geeko device available.
But multiple studies have shown even in arterial disease, they increase the capillary recruitment, and they have shown even in peripheral arterial disease, it's useful, sir. But I'm just limiting, but I'm not sure, sir. But,
so what's the drawback of the compression stocking? So what's the advantage of this over compression stockings?
Advantage being, it can be used in peripheral arterial disease if you have significant arterial disease and heart failure, infection, and it can be a very portable thing, sir. It can be carried anywhere. And main thing, I find the patients who has a fixed ankle and very old people don't have any relatives with them, don't have money even to buy this. They have to change the stockings. They don't have, but this one just a wire only, sir, that's all.
But you have to use it for 4 hours, so patient has to be lie down on the 4 hours?
No, sir, we can use it on work also, sir, during work also. I have used it myself also. It doesn't cause much of
but it causes the tingling, right? Yeah.
Yes, sir.
Have you used it on yourself?
Yeah, yeah.
It's a very bad feeling.
But only a few minutes it was bad, sir. Otherwise, we get accustomed, sir.
Thank you, Rahul. One quick question from
How
Prakash.
much is the cost of the device?
Which one, sir?
The watch you showed.
Watch is 3,000 rupees, sir. It comes as a 2 set, sir. Set of 2. It costs around 5,500 or 5,600, sir. It works only for 24 hours. Otherwise, it becomes dead.
24 hours.
24 hours. It's already set in. The battery works for 24 hours, and after that, it shuts down.
So for 3,000 rupees, just for 24 hours?
Yeah, we have discarded it.
It works for 6 days then?
24 hours, yes, sir.
Thank you. Thank you, Samuel. All right, we have had 5 research papers down, and we have another 5. Before we continue 5, we'll give the judges a small break. We'll just interrupt this for a launch of a book. I would invite on stage Dr. Rahul, Dr. Harinder Bedi, and Dr. Gurjit, please. This is just a small interruption. We'll continue with the papers.
I'd like to invite Dr. Harinder Bedi, Dr. Deepak Selvaraj, Dr. Sanjay Desai, Dr. Gulshan Jeet, and Dr. Raul Jindal to please join us on the stage. We are releasing a magazine which is going to be a pioneer that is launched by Wycon, and this particular magazine will be distributed across all the corporate hospitals in India, and the magazine is titled as Venus and the magazine is titled as Dialogue. We do have with us Dr. S. Maruthu Durai, State Coordinator, Tamil Nadu Accident and Emergency Care Initiative, National Health Mission from Tamil Nadu, joining us here today. Pleasure to have you with us, sir. A round of applause to all our dignitaries on the dais. And to all our dignitaries, I'd now like to request to launch the book. And I'd like to request Dr. S. Maruthu Durai to lead it through.
I'll give a very short introduction.
Yes, over to you.
March, sir, as you, I'm sure you are more aware than us, is DVT Awareness Month. And this is after the journalist, Mr. Bloom, David Bloom, who died. And this is the aim of all vascular societies, to create awareness about a disease which is so easily preventable. And we are really honored that Dr. Durai, who is the NHM Director for the Government of India, is with us. So over to you, Dr. Durai.
I am at my home in this vascular surgeons conclave, and I am very happy to present to the President of Venous Association of India a government order enacted by the government of Tamil Nadu observing October 13th as the World Thrombosis Day, commemorating the birthday of renowned Sir Rodolphe Virchow. This has been issued as a GO, and this is example of government's commitment to the cause of spreading awareness on DVT, as well as adopting top priority to this killer disease in Tamil Nadu health system. So on behalf of National Health Mission and the mission director, I present the GO to the President of Venous Association of India. Thank you.
Thank you so much to all our dignitaries on the dais. I would like to request all of you to pose for a group photograph.
Just like to share a few words here. We are honored to have Dr. Marudhu here. He is one of the senior vascular surgeons in the Tamil Nadu Vascular Society, and he has been a role model to all of us, and not only as a person but as a father, as a parent, as a vascular surgeon. And he has told us how vascular surgery is to be done and how we should look at vascular surgery in the future. Now, we have brought up this magazine because the consortium of accredited hospitals all over the country want to implement venous thromboembolism prevention in a big way. And that is the only reason that we have brought out this magazine in the DVT month. This is March. March is the DVT month. And it has order set tables and everything, including Crapini score and Padua score, and which will probably be implemented in the next few months or in the next year or so across hospitals all over the country. And it will tell hospitals when a patient comes in, medical or surgical, what kind of DVT prophylaxis that you are supposed to give. And we are trying to implement this from the top, from a NABH, and we are hoping the National Health Mission will help us in this as well. Thank you.
Thank you. Once again, a round of applause, please.
We will continue with the sessions now.
We will. Thank you once again to all our dignitaries. We would now hand over the stage to Dr. Sanjay Desai. Once again, over to you.
Thank you. While they take positions back. All right, I think we'll have the sixth paper. Dr. Athirit Reddy will be talking about cephalic vein distensibility. Dr. Athirit. Is he virtual?
So he's coming virtual. There is a small technical glitch. So can we go on to the next presentation and we'll have him in the last.
Okay, so. Okay, by the time Reddy gets, we'll get another Dr. Reddy here, if he is here. Dr. Gnanendra Reddy, please.
Good evening to all. I'm Dr. Gnanendra Reddy from the Department of Vascular Surgery from CNC. My research topic is objective assessment of improvement in health-related quality of life by Servier in patients with complex vascular malformations. Vascular malformations are rare structural anomalies of the blood and lymphatic vessels. They have been classified by International Society for the Study on Vascular Anomalies, which was last updated in 2014. They include venous malformations, lymphatic malformations, arteriovenous malformations. They are present at birth and can appear in childhood or in adults. They can cause diverse problems to the patients like chronic pain, anemia, disfiguration, recurrent infections, coagulopathies, organ dysfunction, or even death. Patients can present with progressive clinical symptoms and worsening quality of life. Traditional therapies include interventional, such as embolization, sclerotherapy, or surgical. However, extensive and infiltrating lesions are not available for such treatment. In these patients, sirolimus mTOR inhibitor was proven effective by studies in case series. This is a prospective monocentric study which was published in 2008. In this 90 patients were administered sirolimus on continuous daily dosing and then subsequently followed up. Sirolimus was found to be efficient in these extensive vascular malformations that were refractory to conventional treatments and was well tolerated. Another study was a retrospective review of 41 patients who were treated with sirolimus from January 2011 to December 2015. There was a successful response rate of 80% in improvement in both radiological imaging and reduction of symptoms. The recent study is a performance trial which was published in 2021. This is a multi-center observational randomized control trial which was performed over 11 tertiary hospital centers in France over a period of 3 years. Overall, sirolimus had positive effects on brain, especially for combined malformations around bleeding, wheezing, self-assessed efficacy, and quality of life. Sirolimus has been proven to improve the health-related quality of life in these patients. Health-related quality of life does not deal only with health-related factors, but also non-health-related ailments such as job, ugly friends, and other situations in life. It includes both objective and subjective components. There are no studies in India as yet to assess the improvement in health-related quality of life in patients receiving sirolimus for complex vascular malformations. The purpose of my study is to assess the improvement in health-related quality of life in these patients with complex vascular malformations who are receiving sirolimus in our tertiary healthcare center. The objectives are to assess improvement in health-related quality of life using available questionnaire. Here it is SF36 is used to assess safety and efficacy of sirolimus in complex vascular malformations. Inclusion criteria are patients age greater than 18 years with symptomatic slow-flow vascular malformations that were refractory to or are considered unsuitable to the standard care. Exclusion criteria include severe concurrent or uncontrolled diseases like cardiomyopathy, diabetes, hypertension, infection, HIV, gastrointestinal disorders that might modify sirolimus absorption, pregnancy or lactation for women, surgical resection or sclerotherapy within the peer 4 weeks, and the peer use of mTOR inhibitor. The study will be a prospective observational study in the Department of Vascular Surgery at CMC level. The study will be conducted over a period of 1 year with a target sample of 30 patients. Suitable patients will be initiated on sirolimus at 0.8 mg per square meter per surface area. After 1 week of treatment, sirolimus level is measured and daily sirolimus dose is adapted to reach the blood level between 1 to 50 nanogram per ml. It will be followed up every month for 3 months and 3 months thereafter. HRQOL improvement is assessed using the SF36 questionnaire at 6 months and 12 months. SF36, as the name implies, is an aggregation of 36 questions. This will be handed over in a printed or in a digital format to the patients in the language they can understand. And the results will be assessed using the appropriate statistical analysis using SPSS 20 software. This is the basic format of the SF36 questionnaire. Sirolimus is proved to be effective treatment modality in patients with slow-flow vascular malformations. SF36 is widely used questionnaire to assess the health-related quality of life, and it can be used to quantify the effectiveness of sirolimus in these patients. Thank you all for your attention.
Thank you, Dr. Reddy. Edwin? Okay. Can we have a mic with Edwin, please? You can pick that, Edwin.
Yeah. I'll take this one. Thank you, Jnanendra. good study. My questions are you going to give this to patients post-intervention or those who are not suitable for intervention? You're muted, I think.
It will be given to the patients who are not suitable for interventions. These patients usually come initially to our OPD and we will send them to the intervention radiology team. So many patients undergo the diagnostic angiogram or minogram, and it seems like very extensive or due to any other cause, they seem we communicate with the radiology team, and when they say that it's not suitable for sclerotherapy or any embolization, then we can straight away start sirolimus starting the sirolimus in these patients. And in some patients who are receiving the sclerotherapy in the initial episodes, and then after the few sessions, they might not get benefited much with sclerotherapy. So in also these patients also we are starting the sirolimus.
And how do you plan to monitor adverse effects? Any blood tests or anything that you'd be doing?
Sir, at the start, at the baseline, before starting, we are doing the lipid profile and platelet counts, and to see for the bone marrow for the baseline value, and also the liver function test. And after that, we'll be checking after starting the sirolimus. At the initial 1 week, we are repeating these tests, and we are following thereafter every monthly for 3 months, and then after 3 monthly to follow up. Sir.
And finally, what's the duration of sirolimus you're going to give for these patients?
Actually, there are such many studies, but there are no any studies which have given the finite period for this sirolimus duration. But many patients may require the long-term duration, maybe even the lifelong, and we should monitor for any adverse effects. In which case, we might need to modify the dose also.
So, what dose you are going to use? So, what are the doses you are going to use in this?
So we are starting off with 0.8 mg per square meter body surface area, and then we are monitoring after 1 week with the sirolimus serum values of sirolimus. Yeah. And then we are if the values doesn't reach in that level, and then we are going to increase to 1 mg per square body surface area.
Yeah. If some patient is found to have a high sirolimus value, what will you do? Will you stop and restart, or completely you? What's your strategy in this patient?
So we'll see for if the patient is developing any complications, and we'll again mainly the clinical profile and investigations. If he's having any bone marrow depression or any high lipid profile abnormality or liver function test we are seeing. And if it is too high, then actually we didn't encounter much, but the literature they say that we can stop the sirolimus for some days, and then we can repeat the sirolimus values, and again we start again the sirolimus. But we have not encountered such high levels of any sirolimus.
It comes as tablets, is it? Because I've not used before. I've only heard of propranolol. What strength tablet does it come, sirolimus? Tablet or a solution? How do you give it?
It comes as a tablet.
What strength?
It comes as 1 mg tablet. It comes.
It's also available as a syrup. Thank you. We have used it in the kids.
Thank you, Dr. Gnanendra.
I just have one question.
Sorry, Deepak has got a question. One last question. Yes, Deepak.
Is my trainee, but anyway, I want to ask him a question. Narendra, what is the molecular basis of using sirolimus in venous malformations and AVMs? What is the molecular basis? Why are you using sirolimus then?
Sirolimus actually, it is anti-proliferative agent, sir. It acts on, it is a mammalian target of rapamycin inhibitor, which inhibits the PI3K and APT pathway, which is responsible for the proliferation. So these vascular malformations, even though these are not proliferative tumors, other like vascular tumors, but it is seen that the sirolimus has shown good improvement clinically and also radiologically in these malformations and slow flow AV malformations. But it is not effective in high flow AV malformations.
Thank you.
Thank you.
The concept is to treat AVMs and huge VMs as tumors,
vascular tumors. So that's where you bringing in sirolimus and all this gene modulation and all these things. So that's where you have to make a distinguish between normal venous malformations and venous malformations which are very large in AVMs, which have genetic ramifications. So that's where you are introducing sirolimus. So you have to be very clear on which patients you can use sirolimus and which patients you can not use sirolimus. So are you doing any genetic testing on these patients prior to using sirolimus?
So these patients we are referring to hematology, and we are doing the we are following up with the hematology. So we are integrating with hematology, and we are doing the genetic testing in these patients.
So recalcitrant tumors, recalcitrant patients with AVM, and patients who have ulcers, and patients who we are not able to treat by standard operating procedures and standard procedures, we are referring them to hematology and getting an opinion and then doing it. You have to be very clear on what you are trying to say. Which
All right.
patient you are using, which patient not using.
Thank you, Deepak. Is Dr. Adirath ready now? Sam? We're going to Ankush Sharma. So judges, please note, I think we're going to Ankush Sharma. This is paper 7. Dr. Ankush Sharma.
Am I audible, sir? Good evening, sir.
Yes, Ankush, you're audible. Your slides are visible. Yes. Number 7.
Good evening.
Number 8.
Yes. Good evening, everyone. I'm Dr. Ankush, surgery resident from the Banaras Hindu University, Varanasi. Today, I'm going to present a gene expression study in venous ulcer. Regarding the background, as we know, there is a necrosis of the extracellular matrix. Previously, the things which were included, that matrix metalloproteinases, specifically 1, 2, 8, and 9, which play a significant role, and also the cytokines various like vascular endothelial growth factors and TNF alpha. In this study, I have considered 4 genes, that is E2F1, RAD21, NIPBL, and VACMAR1 gene. Regarding the E2F1, this hinders with the skin wound healing by suppressing the vascular endothelial growth factor expression, also the neovascularization and macrophage recruitment. The RAD21 and NIPBL gene, both of them play a significant role in the sister chromatid cohesion and during the mitosis process. The VACMAR1 gene, this gene plays a crucial role in the keratinocyte migration, and the deficiency of this protein impairs the wound reepithelialization. The aim of the study is to analyze gene expression. That the genes undertaken are the RAD21, VACMAR1, E2F1, NIPBL in patients with venous ulcers. It is a prospective, observational, analytical, hospital-based study. 30 patients are taken into consideration. Inclusion criteria: patients diagnosed with venous ulcer between age 18 to 50 years. Those were excluded were having arterial insufficiency, lower limb filariasis, pregnancy, and diabetic foot ulcers. Wedge biopsy was taken at the start of the treatment in all the patients, and second sample was taken after 50% reduction in size of the healing ulcer or after 2 to 6 months in non-healing ulcers. This is the gene sequence for the primers of the genes undertaken from the standard NCBI database. Tissue sample collected was stored at -80°C, thawed and dissected into small pieces. Standard RNA extraction protocol was followed. The integrity of the RNA was assessed using 1% agarose gel, and the RNA was analyzed by one-step RT-PCR, and the control gene was taken as the beta-actin gene. The CT values were collected and assessed. The RNA, this is the gel electrophoresis showing the intact RNA, that is the ribosomal RNA 28 and 18S in the different samples. The statistical comparison using GraphPad Prism version 8.0.2 and the p-value of less than 0.5 considered significant. The RAD21 gene expression was significantly increased in the healing as compared to non-healing ulcer, and also in the treated patient after treatment, and the same as that of NIPBL gene. the expression has been significantly increased in healing ulcer as compared to non-healing, but not significantly increased, though the expression were increased after treatment. There were no expression seen of the E2F1 and Brakmar gene. This is the bar graph showing NIPBL and RAD21 gene related to the beta-actin gene post-treatment. This is the crux of the study, in which the RAD21 gene expression increased significantly in tissue sample from venous ulcer patient post-treatment. The NIPBL gene follows the same, but the Brakmar1 and E2F1 were noticed without any expression in pre or post-treatment part. As we know, venous ulcers were slow to heal and cause significant morbidity and impact on quality of life. The gene expression studied for ulcer healing are therefore important in helping to identify the potential slow healers who might benefit most from the newer treatment options. These genetic expression profiles displayed here may have implications for the development of the novel therapies for venous leg ulcers, or the expressions may act as the prognostic indicator for the venous ulcer healing. The interpretation I've already told, RAD21 and NIPBL gene in healing venous ulcer were relatively expressed more as compared to the non-healing ulcer. The future points can be these genetic expression can act as a potential point for the targeted therapy to promote healing and also the prognostic factor. Thank you.
Thank you. Dr. Edwin again.
Sorry, very nice study. Thank you. Something new. You said that this could act like a predictive or a prognostic factor. How? Because it's only after the intervention that you know that the expression of a certain gene signature has become more visible.
Sir, we have collected the sample before giving foliar compression therapy to the patient, and the expression were noted, and then after giving treatment, that is foliar bandage in healing, or 2 to 6 months after in non-healing ulcer, we have again checked the expression of these genes, and then we have compared whether they are significantly increased or not. We are checking the expression both pre-treatment as well as post-treatment.
May I know what the cost of the test is?
Sir, it is an experimental thing, sir. It has been totally under the surgery department of Banaras in the university, sir, actually.
So did you do a cost analysis roughly? I mean, some idea how much it might cost? No.
Sir, in 30 patients, it cost overall around 60,000, sir.
Okay. So
pre and post treatment.
So basically, the patient has to do the test before intervention, then another test after that, for us to know whether it will benefit or not.
Currently, yes, sir.
Okay. Thank you.
Thank you so much. I just want to say that this is a very wonderful study that you have done, and
thank you.
Gene expression in venous ulcer has been of a lot of interest to the venous surgeon of India. And especially RAD21, that's the gene that we're all very interested in. And why do some people have venous ulcers and some people with completely blocked veins? They have no veins at all. They are deep veins. There's no deep veins, but they don't have ulcers. I've had several patients who have no deep veins, but they don't have ulcers. They have symptoms, but they don't have ulcers. So there's a lot of things that we don't understand in venous disease, and I'm really grateful that you brought something very important, that there's a genetic component to all these venous ulcers. And I think you should actually take this forward and make it a multi-centric study.
Yes. Sure, sir.
Excellent study. One small doubt, how specific is this gene to venous ulcer? One. Another is, do you simultaneously look for the FOX gene? There is supposed to be one of the genetic gene expression in varicose veins. Since you are already investigating, do you have a subgroup study or something like that in these two?
So regarding the first question, this specificity of these genes, actually these genes has been studied earlier in the mitosis process and the cell cycle process, and in relation to the uh, other ulcers, but no previous study related to the venous ulcer has not been anywhere in the journals regarding these genes related to the venous ulcer, and I have not underwent any other genes. Only these 4 genes has been studied in these studies. No side genes were studied.
All right. Thank you. Thank you very much, Ankush.
Thank you, sir.
Thank you. So we will move on to the next paper, Dr. Vishwanath Etria.
Good evening, everyone. I am Vishwanath from Care Hospitals, Hyderabad, and I shall present our work on prevalence of deep vein disease in patients with chronic venous insufficiency and a comparative study between MR venography and IVUS. Chronic venous disease affects 5 to 20% of the global population. Management of patients who develop CVD secondary to deep vein lesions remains a clinical challenge with respect to patient selection, diagnosis, treatment, and prognosis. There are very few studies regarding prevalence of such lesions in CVD patients, and there is no published Indian data in this regard. Our aim was to study the prevalence of non-thrombotic deep vein lesions in patients with chronic venous insufficiency using MR venography, and to compare MR venography to IVUS, which is considered the gold standard. So we conducted this prospective pragmatic study with 132 patients in our department from November 2019 to September 2021. We used descriptive statistics and used Microsoft Excel for data analysis. The mean age of our study group was around 50 years, with most of the patients in 6th and 7th decades of life. Majority of our patients were male and were overweight, with a mean BMI of around 30. About 40% of the patients had either left-sided disease or bilateral symptoms each, and half of the patients belonged to stage C4 of the SEEP classification. GSV reflex was the most common pattern of reflex seen in our half of the patients, and about 37% of the patients did not have any reflex on their duplex scan. All the patients underwent 2D non-contrast MRV, time of flight imaging in supine position. About half of the patients had stenotic lesions, while 6% of the patients had occlusive venous disease. 42% of the MRVs were normal for deep vein disease. Left common iliac vein stenosis was the most common lesion found in about 40% of our patients. Prevalence of deep vein disease was high in patients younger than 30 years, those with a normal BMI compared to the obese, those with left-sided symptoms, in patients with venous ulcers, and in patients who did not have reflex on duplex examination. All these groups had a prevalence of around 60% or more. About 1/3 of the patients with recurrent varicose veins had deep vein lesions on MR venogram. 25 patients among these underwent IVUS examination of their deep veins with Phillips volcano system. 19 patients had a positive IVUS and 3 had a negative IVUS for deep vein disease when they had a positive MR venogram. 3 patients had a negative MR venogram as well as IVUS. So when MRV was compared to IVUS, it had a high sensitivity and a negative predictive value, but not very high specificity for deep vein disease. So the limitations of our study are a small sample size when comparing IVUS to MR venogram. Ours is a pragmatic study, and results may not reflect the true prevalence of deep vein lesions in patients with chronic venous insufficiency, but they do reflect what can be expected in a daily clinical setting. We did not follow any set criteria to select patients for MR venogram. It all depended on clinicians' intuition and patients' acceptance. So there is a selection bias in our study, and limitations of MRV are inherent to our study. So there are 4 studies which reported prevalence of deep vein lesions in CVD patients, and all of them reported a prevalence around 20 to 60%. One study that compared MR venogram to IVUS reported a similar high sensitivity of MR venogram in diagnosing proximal deep vein lesions. So to conclude, within the limitations of the study and MR venogram, the prevalence of deep vein disease is high in patients with chronic venous insufficiency. MR venogram has an excellent potential as a screening tool in diagnosis of these lesions. Patients with venous ulcer, recurrent disease, absence of venous reflex on their duplex scans, left-sided symptoms may benefit from evaluation of deep venous system before intervention. Thank you.
Thank you, Vishwanath.
Thank you, sir. Can you hear me, sir?
Yes, we can.
Yeah.
Okay. Yeah, before that, just one question. What deep venous disease or insufficiency are you looking for in your MR venography?
We were looking for proximal deep vein obstructive or stenotic lesions, mostly stenotic lesions.
So mostly stenotic or obstructive lesions?
Yes, sir, in the islet veins.
So not looking at reflux?
Reflex we anyways evaluate in the with the duplex scan in our clinic.
Okay, so what you're trying to say is that you're selecting these patients as a non-invasive module before you take them for IVUS. Is that
IVUS,
what
yes, sir.
is your
Yes.
conclusion? So,
Yes,
and
yes.
obstruction is what you're looking for?
Yes, sir.
All right. Edwin had a question? No, okay. Any other questions? Dr. Doraraj, sir?
What was the status of the valves in IBS findings? Were they competent or just incompetent valves?
We did not look at the, we did not report the nature of the valves on IVUS, sir. We were looking at the cross-section areas and the diameters. That is what we are looking on IVUS.
Chronic venous insufficiency major may be due to valve reflex or valve insufficiency or hypoplastic valves.
Yes, sir, that is true. But when Dr. Raju and Neglan, when they reported in them, they told that the correction of obstruction will itself correct the reflex itself, and there is no need to look for reflex specifically. So we did not look for deep vein reflex on IVUS or the valve status. We were looking for stenotic lesions only.
Good evening. Excellent study. But one small doubt is, do you have any scoring systems before taking up this patient for such an invasive modality of investigation 1?
Yes, sir.
And 2, do you just randomly choose, because you yourself said there is a selection bias, right? So what stage of clinical disease, or if it is a PTS, what is it, moderate Villalta score or a severe Villalta score? Those patients you take it for
No, sir.
invasive?
We excluded all the patients with DVT or previous history of DVT because that will skew the results towards a higher prevalence. Because when you have a PTS, we obviously are going to find more deep vein lesions because of the residual thrombosis or so. So we are not looking at lesions in patients who had a history of DVT. This is for patients with pure venous disease without a history of DVT.
So NVIL you are looking at, is it?
Yes, sir. NVIL, yes.
All right, thank you so much.
Thank you, sir.
We'll move on to the next paper. Okay, Dr. Hanish Kataria, please. He's going to talk to us about feasibility study of virtual management of venous ulcers.
Good evening all. I'm Dr. Hanish Kataria, MCH Registrar in Department of Vascular Surgery at CMC Vellore. And topic for my research proposal is feasibility study of virtual management of venous ulcers. I don't have any disclosure or any conflict of interest. As we all know, venous ulcers, they account for approximate 70% of lower extremity ulcerations. And they are often recurrent and they can persist for weeks to years. And despite low prevalence of 1 to 2%, they have a significant socioeconomic impact due to the cost of the treatment involved and the patient loss of working days. So assessment of any ulcer is based on the quantitative and qualitative evaluation. So in clinical practice, acetate dressing is the standard technique used for measuring the wound surface area. However, it is not possible to use in daily practice due to the non-availability of the material and contamination of the wound, and it is time consuming. Then the digital photography with the post-processing software have been developed for the wound assessment, but this is possible only in the either the institutional setting or in the hospital practice. So then recently the planimetry techniques which are developed with the mobile health apps, they are used to overcome these difficulties. So in a study published in Journal of Vascular Surgery Cases and Innovation Technique 2021, 85 wound assessment were done and using the smartphone based app, and they were compared with the digital photography and the post-processing software. And they analyzed, they concluded that there is a smartphone based app, they have excellent accuracy in measuring the wound surface area using these methods. However, there are no reported studies in India for management of chronic wounds using the smartphone based technology. So purpose of this study is to assess the feasibility of the venous ulcer management using smartphone based app and telemedicine facility at tertiary level care center. So objective is to assess the ulcer healing in patient with a primary venous insufficiency and to assess the willingness to use technology and patient satisfaction using the client satisfaction score 8. So all the patients with active venous ulcers who had undergone either the endoablation or sclerotherapy or undergoing conservative management will be included in the study. And patient with the post-thrombotic limbs or ulcer with the circumferential shapes or patient without smartphones will be excluded from the study. Now this will be a prospective observational study in the Department of Vascular Surgery at CMC Vellore and with the target population of 40 patients and with the time limit of 6 months. And willingness to use technology will be assessed by a simple questionnaire during the first visit at the hospital. This is a specific questionnaire which is about the usability or availability of the smartphones and the usability of the smartphones for the patient. Then wound assessment will be done by healthcare professional at first visit using the ImitoMeasure app, which is available free of cost on the iOS and the Android platform. And this app has an inbuilt photographic technology, and wound area will be assessed after taking the photograph, and basically you can encircle the wound with the finger and you can take the circumference and the area of the wound. After the initial assessment by healthcare professional, rest of the assessments will be made by the patient or relative. They will be given the proper training for using the app, then measuring the wound area at home. And standard care of treatment will be taught for each patient after appropriate intervention or about the conservative management. Then wound report will be shared via email every week, and patient will be consulted once or twice weekly via teleconsult facility for the follow-up. So patient satisfaction will be assessed by client satisfaction score, which was used in Middle East for wound assessment in the hospital settings, but because of the simplicity of score, it can be used in the virtual setting also. And healing rate will be assessed every week for 8 to 12 weeks. Now, rationale for the study is this mobile health app, particularly ImitoMeasure, have been already validated, and it is a reproducible app and have been assessed for the wound in different scenarios in the West already. And regarding the patient usability of the smartphone application, it has been found in one study that it took only 4.7 minutes on the training and 5 minutes to complete the session. And 56% of the patients were able to complete the app independently. So the patient who are attending the tertiary level care center, they are basically from far away states. So it is difficult to come for the patient, and this study is basically to make the treatment of venous ulcer cost effective and to decrease the loss of working days. So in discussion, I'll say that smartphone incorporating high definition cameras are already available and can be used for clinical applications, and they can be used as a point of care tool for assessing the healing of venous ulcers. And this study will help us in the development of wound assessment app for the Indian patient in near future. Thank you.
Thank you, Anish. We have had very serious problems with these apps and the digital photography measurements, which we have used the actual cameras, not the apps. And every time you mark, the cursor tends to move away. And there is a human component in it because you are the one who are pointing out and telling where the edges are to be measured. So how do we get over that problem?
Definitely, sir. This is this like the ultrasound. It is also operator dependent. It is also app. So it's operator dependent. That's why the training will be given and it will be seen for every patient or the relative. If the patients are not cannot use the smartphones properly, then one of the relative like son, daughter, they can use it effectively. And we have already tried on 2 to 3 patients which are sending by WhatsApp messages. And initially 1 or 2 times we have some different, that area has come more or less. So, but with every week, we are seeing a change that the reports are, that is correct measurement is done.
No, definitely. I mean, I'm not telling you, because this is a problem with digital, because we have seen over the last decade, it's always been a problem measuring. One of the ways to get over it is to have it blinded. You know, get the photograph to a third person who's blinded and he does the marking. So
Okay,
that's the best way to have a authentic research and analyzed.
So first, basically, we are first. There is no study for published at least for use that whether we can use or not. So this is a feasibility study for assessing that whether we can use these app in our Indian patients. So after that, definitely, first we will check the feasibility, and then second will be to compare it with the conservative, with the patient who are coming to hospital. So that will be the second step. And along with that, if it is feasible, then we can develop an app for the Indian patient, because only 1 or 2 apps which is available free of cost. Rest are all like in West, they have associated with the particular university or like that, so you cannot use them.
Yeah, there are a lot of challenges,
Yes,
including the distance you take the picture,
Yes, sir,
how
yes, sir.
far you're taking
Definitely,
it,
sir.
what light is there. So there are a lot of issues because we
Yes,
have
sir.
gone through this. It's still refining.
Yes,
but, good to know that there is an app. What's it called? Imito
Imito Measure.
Imito app.
Yeah.
Okay. Yes, Edwin.
Thanks, Anish. Moving with the times, that's good. What was the reason or the basis behind dropping out patients with post-thrombotic limbs or ulcers with circumferential shapes?
First, so patient with the post-thrombotic limbs, the ulcers, they are difficult to heal and they need further assessment and maybe other intervention. So that's why we have not included those patients. And with the circumferential shape, obviously if we are taking photograph, we will not be able to take the photograph of a circumferential shape of the circumferential ulcer which is present all around the leg. So it is difficult to measure the area. That is the reason behind.
I think the second one completely acceptable, but if your app is meant to only assess whether there is healing or not, how does it matter whether a post-thrombotic ulcer doesn't heal or does heal?
Basically, sir, the rationale I told you, because patients are coming from the faraway area, and like for patient to CMC who are coming there from West Bengal, Bihar, Jharkhand. So sometimes the patients in which we can make it cost effective, that's why we have included the patient with a primary venous insufficiency. While the patient like with a post-thrombotic limb, it may not be possible that those ulcers will heal with the conservative management which like with the management they are doing at home, and if they require further assessment, they have to come to the tertiary level center again. So that's why just to make it more effective, so we have included only patient with a primary venous insufficiency.
Thank you. One last question. What made you reach that number of 40?
Sir, it is basically a feasibility study, so it's kind of a pilot study. So in the pilot studies, it's like the number should be more than 30. And it's based on the different previous studies done. So minimum requirement is 30, and then or in each arm can be 12 patient in each arm, and some studies says it can be 50 also. So it is according to the previous studies published that how much sample size is required to do this feasibility or pilot study.
Okay, thank you, Dr. Kataria.
Thank you, sir.
Do we have Tirath ready? Yes, we do. So the last presentation, Dr. Reddy, you are ready?
Am I audible, sir?
Yes, very much. You can start your presentation.
Good evening, one and all. I'm going to present on cephalic vein distensibility as a predictor for AVF maturation. I'm from SRMC Chennai. Coming to the introduction, hemodialysis is the commonest modality of kidney replacement therapy, and AVF is recommended as the best permanent vascular access among all due to its prolonged patency, increased longevity, and minimal risk of infection. And large vein diameter has proven to have a decreased failure rate and associated with a better patency. Of all the features, dilation of the vein is an important feature which occurs because of increased blood flow and consequent shear stress after creation of the fistula. Coming to the objectives of my study, we hypothesized that sufficient venous distensibility contributes to fistula maturation. Therefore, this study was done to assess the influence of cephalic vein distensibility on fistula maturation. The study was conducted from Feb 2021 to Feb 2022, and all the patients who were having end-stage renal disease and undergoing a new radiocephalic fistula were included in the study. And patients with severe vessel calcification and who are in hypertension and central venous stenosis were excluded from the study. Coming to the materials and methods, baseline demographic indices were noted and a duplex ultrasound examination was done preoperatively and postoperatively at 2 weeks and 6 weeks after the surgery. The diameter of the distended cephalic vein was measured by application of a tonic-wet and 3 minutes after the inflation of the tonic-wet. And we calculated the distensibility and vein distensibility ratio. Distensibility is calculated by the difference between the post-dilatation and the pre-dilatation, and the distensibility ratio by the dividing post-dilatation diameter by the pre-dilation diameter. Later, the AVF was done, and we have considered the vein AVF to be matured by noting the flow volume, which was greater than or equal to 500 ml per minute, and if the vein diameter was more than 5 mm. Coming to the results of my study, the mean age group of the study population in my study was 52.32 years, and most of them were between 51 to 60 years. And most of them were males, which accounted for 55%, and females of 45%. 72 patients were found to be hypertensives, 52 had diabetes, and 22 had a history of coronary artery disease. The mean duration of CKD in my study was 19.45 months. And coming to the cephalic vein and radial artery parameters, 46 patients had a diameter pre-dilatation between 2 to 3 mm, and post-dilatation 52 had between 2 to 3 mm, and 72 patients had an increase of about 0.1 mm to 0.9 mm. 50 patients had a distensibility ratio of 1.2, and radial artery diameter, 54 patients had between 2 to 3 mm, and post creation of fistula, the vein diameter at 2 weeks was 3 to 4 mm for 48 patients and between 5 to 7 mm for 50 patients. And 52 patients had a flow rate above 500 ml per minute, that was about 65%. And after comparison of all the variables, we found that there was no statistical difference in maturation for the below parameters like age in years, BMI, and duration of CKD. And there was also no statistical difference with respect to the various comorbids like hypertension, diabetes, and CAD. But there was very significant difference between the maturation and non-maturation group with respect to the dilated cephalic vein diameter, distensibility vein ratio, and the distensibility of the vein, where the p-value was less than 0.05. Coming to the discussion, maturation failure following radiocephalic AVF formation is an important but unresolved issue. Other parameters like females, diabetes mellitus, diameter and compliance of the artery and vein are all found to influence the maturation failure. We considered vein distensibility to one of the factors. Various studies have documented that patients with large vein diameter have a decreased likelihood of fistula failure. Our study revealed no relationship between fistula maturation and cephalic vein diameter, but preoperative vein distensibility significantly affected the AVF maturation. So I would like to conclude by telling that cephalic vein diameter cannot be considered as the only independent predictor for AVF maturation. Degree of distensibility also has a role in determining the fistula maturation success. We also would want to assess AVF maturation success in patients who have small diameter but elastic veins which are deemed unfit for fistula creation. Thank you.
Thank you, Aturit. just to get a clarity on what you're presenting, so you dilate the vein or you put a tourniquet after a fistula is created and measure the vein?
No, sir. Before the creation of fistula, we assess for the distensibility of the veins. Sir. By preoperatively, we apply a tourniquet and see the distensibility of the veins.
So you measure the cephalic vein after you put the tourniquet?
Yes, sir.
Okay, before
we
the
inflate
fistula.
it and before the fistula is created.
Before the fistula is created. And you spoke about shear stress on the distensibility. So what are you trying to prove from this study?
We're just trying to tell that few veins might be having a very small diameter before, sir. But if they are really distensible by the application of a tourniquet, we can still attempt doing that radiocephalic fistula. Because the kidney patients, chronic kidney disease patients will require so many access. We just can't eliminate that the radiocephalic vein diameter is less and we can't
Okay, I'll put it the other way.
Exclude from not doing the radiocephalic.
Okay, have you heard of any studies where they put a tourniquet after the fistula is created, an intermittent tourniquet is put after the fistula is created? Have you heard of anything
no,
like that?
sir.
Not heard of that.
I'm not aware of it.
What are the features for maturity? What are the factors which causes the vein to dilate?
One is the vein should be really elastic. It should be distensible.
Okay, let me again put it different. Is it an inward remodeling or an outward remodeling that happens in a vein?
So outward remodeling which happens in a vein.
Okay, what induces this outward remodeling? No, this has to do with the tourniquet because I was trying to understand the study. So, you know, what really causes the vein to distend eventually after fistula is created? Whether you put a tourniquet or not, there is increased shear stress when you connect the vein to the artery. So there is increased pressure which is on the vein, and that starts acting on the vein wall.
Yeah, but if the veins are not found to be too elastic, even if the vein diameter is big, then there might be a failure of the fistulas.
Okay. Any other questions? Okay, Atrit, just since there are no questions, see the remodeling happens invariable. It's not the elasticity which matters. It is the amount of nitric oxide which releases, and that triggers the remodeling. So you can have an outward remodeling, you're right, that's the outward remodeling, but that doesn't have anything to do with the elasticity. Okay, there is some amount of pressure, the shear stress, how it acts on an artery, there is something similar which acts on a vein. All right, thank you, Atrit.
Thank you, sir.
So that's the last paper. We have had 10 wonderful presentations, and the judges have done their job. I think you will have the results tomorrow. So I'd request all of you to be there tomorrow towards the close of the session to know the results. Thank you, judges. I know there are quite a few of them. Thank you, all the participants. Thank you.
Thank you so much, Dr. Sanjay Desai, and thank you to all our judges. Let's give them a round of applause, please.